Welcome to the deep dive. Today, we're plunging into a system that's, well, it's a massive source of national pride in the UK, but also increasingly a focus of really intense debate.
You mean the National Health Service, the NHS?
Exactly, the NHS. Our sources describe its birth, quite powerfully, I think, as a radical experiment in social solidarity.
But today, you hear it described very differently, like it's gasping under weight it wasn't built to bear.
Precisely. So our mission for this deep dive is to really unpack that. Where did the NHS come from? How does it actually work day to day? And how's it funded?
And maybe more importantly now, what are its core challenges? Why is it under so much strain?
Yes, and crucially, what potential fixes are out there? Our sources talk about some quite blunt fixes. We want to pull out the most important nuggets from the material you shared with us.
Okay, sounds good. It's a fascinating story.
It really is. Let's dig in. What strikes me first, thinking about its birth, is just how ambitious it was for its time.
Oh, absolutely. Revolutionary, really.
Can you imagine proposing something like that today? It officially opened, was it July 5th, 1948?
That's right, under the 1946 Act. And at its core was Aneurin Devon's idea.
Which sounds surprisingly simple when you boil it down. Comprehensive health care?
Free when you need it at the point of use.
And paid for through general taxes. Simple, but huge.
It really was. It brought together hundreds of, existing local health schemes, council hospitals, charities.
And all into one national service. With the goal, quite profound really, of treating everyone the same.
Whether you were a duke or a dustman, as the saying went.
So how did that foundational idea shape its growth? What happened next?
Well, through the 50s, 60s, 70s, it basically expanded. More hospitals, more staff, more specialisms developing.
Okay, straightforward growth phase.
But then, from the Thatcher years, things started to change. Successive governments began tinkering.
Tinkering how?
Introducing things like internal markets, setting up commissioning bodies, using private sector contracts more.
Often pitched as being about efficiency, right?
Yeah. Yes, efficiency was the watchword. But it also sparked these big debates about, competition versus collaboration in healthcare.
And then came the really big shakeup.
The 2012 Health and Social Care Act, Andrew Lansley's reforms, that was massive.
What did that actually do?
It scrapped the regional health authorities, basically. It handed the commissioning power, the power to buy services to groups led by GPs, the clinical commissioning groups, or CCGs.
Right, I remember the CCG.
And it also carved out NHS England as a sort of separate executive body. The idea was more local control, but...
But some argued it just created more fragmentation. Different layers.
Exactly. It was a huge shift in structure. What's fascinating, though, is how that core principle, free at the point of use, has somehow persisted through all these internal changes.
That persistence is definitely a testament to its appeal, isn't it?
It absolutely is. But you do have to ask, has that ideal become more of a political statement than an operational reality in some ways, especially given how much the funding and structures have mutated?
That's a really sharp point. So, okay, we've glanced at the past. How does this huge system actually operate today? Where does the money flow?
Right. So basically, HM Treasury allocates the money to the Department of Health and Social Care, the DHSC.
Okay.
From there, it goes to NHS England. Then it flows down to 42 regional bodies. They're called Integrated Care Boards, or ICBs.
ICBs, right? And they pass it on?
They pass it on to the local providers, your hospitals, your GP networks, community health services, mental health trusts, and so on.
Got it. And in terms of what services are free?
Well, the big ones are A&E, seeing your GP, hospital stays, mental health support, maternity care, most outpatient stuff, still free at the point of use.
But there are some exceptions?
Yeah, a few.
Yep.
Some dental work, eye tests and glasses, and prescriptions carry charges unless you're exempt for various reasons.
Okay, now let's talk scale, because it's just monumental, isn't it?
It really is. With 1.36 million full-time equivalent employees, it's Europe's biggest employer.
Just think about that. 1.36 million people. Bigger than the population of some countries?
It's immense.
But here's a detail from the sources that immediately flags up the problems. Despite that huge size...
Vacancies.
Exactly. 1 in 10 posts in England is currently empty.
And that's not just a number. That's tens of thousands of gaps. Nurses, doctors, support staff. It raises a massive question, doesn't it?
Which is?
How can an organization this vital, this reliant on its people, actually deliver what it needs to deliver with so many unfilled roles? How sustainable is that?
It seems unsustainable. It's a huge hurdle. So let's follow the money then. Where does the funding actually come from for this colossal enterprise?
Well, the vast majority, over 95%, comes from general taxation and national insurance contributions, straight from the public purse.
And the rest, those patient charges we mentioned.
They bring in a tiny fraction, really, about 1% of the total budget.
Okay, so it's overwhelmingly taxpayer funded. What are the actual numbers we're talking about?
For England in 2020-23, the total NHS bill was, wait for it, 181.7 billion.
Wow, and that's a huge chunk of the health department's budget.
Over 40% of the entire DHSC budget. And by 2024-25, it's expected to be pushing towards 190 billion.
The numbers are just vast. But the critical point from the sources isn't just the size, it's the rate of growth, isn't it?
Exactly. That's the crucial bit. If you look back, from 1948 right up to 2010, NHS spending grew, on average, by about 4% a year in real terms, so above inflation.
Right, steady real terms growth for decades.
But since 2010, that real terms growth has slowed dramatically. It's barely kept pace with inflation, maybe averaging about 1% growth per year.
While demand
Has just soared. An older population, more complex treatments becoming available, more chronic conditions, the pressure has ramped up enormously.
So funding growth flatlines in real terms while demand goes through the roof.
Precisely, and that's the bottleneck. It's like asking that marathon runner, as you said, to keep going faster while reducing their water intake. Something has to give.
And what gives often seems to be staff morale, leading to strikes. You can't really talk about the NHS today without mentioning the industrial action.
Yeah. No, it's been incredibly disruptive. We saw that big wave across 2022 to 2024. Multiple unions involved.
Nurses, for instance, the Royal College of Nursing.
Yes, their first ever strike action back in December 2022. Overpay offers that just weren't keeping up with inflation.
Ambulance staff joined in too.
They did, citing unsafe staffing as a major factor alongside pay.
And junior doctors, or resident doctors, as they're often called now.
Repeated walkouts through 2023 and into 2024. Their core demand was about restoring pay back to 2008 real terms levels. They argue there's been a huge erosion over that period.
And it's not over, is it? There's another potential flashpoint coming up.
Yes, mid-2025. Resident doctors in England have voted for another 5-day strike, July 25th to 30th.
And their demand.
It's significant. They're asking for an extra 29% on top of a recent 2-year deal, arguing their real pay is still way below where it was in 2008.
And the government's position?
Is that it's simply unaffordable without cutting services elsewhere. It's a real standoff.
So what are the root causes driving all this disruption? It feels like more than just pay.
It definitely is. Pay erosion is huge, obviously. Junior doctors' real pay down nearly 30% since 2008. That's massive.
Okay, so pay is number one.
Then there's the general inflation squeeze affecting everyone. Staff offered, say, 3.6% when living costs were rising much faster.
Number three.
Workload and morale. Chronic understaffing just grinds people down. Longer hours, canceled leave, burnout. It's pushing people out.
And finally,
a kind of bargaining breakdown. There's no agreed long-term way to link pay rises to inflation or demand or even the overall NHS budget increases. So you get these constant, often bitter ad hoc fights.
It sounds like a perfect storm. Falling real wages, rising living costs, impossible workloads.
It really is. And it's not just about morale, is it? It fundamentally hits the NHS's ability to deliver safe care. You have to ask, how long can you run a service on goodwill when pay and staffing are so stretched?
So the strikes are a really visible symptom.
Yeah.
But what's the deeper illness here? Why is the NHS struggling so much?
Our sources point to several interconnected things. Firstly, that funding versus demand gap we talked about. The flat cash growth just can't cope with an aging population and more complex, expensive treatments.
And the IFS, the Institute for Fiscal Studies, they had a warning about this.
Yes. They basically said that without at least 4% real terms funding increases each year, services will have to be cut. It's stark.
Okay, funding gap. What else?
Staff shortages. We mentioned the vacancies near a decade high in England. This forces reliance on expensive agency staff.
Which costs a fortune.
Absolutely. £130 million a year just on agency nurses and doctors in Scotland alone, for example. And it impacts safety. 2/3 of nursing shifts below safe levels. Red flag safety events up sharply.
So funding, staffing. What else is causing the strain?
System bottlenecks. Things like A&E corridors filling up because there are no beds on wards, ambulance delays outside hospitals.
And patients stuck in hospital beds even when they're medically fit to leave.
Exactly, because there isn't adequate social care or community support available for them. That blocks up the whole system.
Then there's the physical infrastructure.
Yeah, aging buildings. A massive maintenance backlog, 13.8 billion needed just to fix things. And the tech often lags behind. Patchwork digital systems that don't talk to each other properly.
Wasting time and effort.
Definitely. And finally, the sheer structural complexity. You've got the DHSC, NHS England, the ICBs, individual hospital trusts. Lots of layers.
Which can mean duplicated admin and fuzzy accountability. Hard to know who's really in charge of what.
Precisely. It all adds up. It really paints a picture of a system where, every part is under immense pressure.
And they're all interconnected, so a problem in one area just ripples through.
That's the key thing. Lack of social care beds means A&E gets clogged, which means ambulances way outside, which means slower response times. It's a cascade, a truly overwhelming burden.
It sounds incredibly daunting. But the sources do offer some potential solutions, these blunt fixes. What are they suggesting?
Well, first up is obviously funding. A proper reset. They suggest committing to funding increases of inflation plus 2% in real terms, guaranteed over the next decade.
And ring fence for the front line.
Yes, specifically for frontline care. There's also talk of maybe exploring a specific earmarked tax, a hypothecated levy perhaps for social care, to provide more stable revenue.
Okay, funding first. What about the workforce crisis?
A major overhaul. Honoring the NHS long-term workforce plan is key. That means things like doubling medical school places to 15,000 by 2031.
That's a big increase.
Huge! And boosting nurse training places by 24,000 a year, expanding apprenticeships. Plus, crucially, things to keep experienced staff, like modernizing pensions and offering more flexible working.
Makes sense. Then modernization.
Tackling that huge 13.8 billion capital backlog for buildings and maintenance, and a big push on tech, rolling out unified electronic patient records across the board, using AI for diagnostics, more remote monitoring, bringing it into the 21st century.
Right, and simplifying the structure.
Yeah, potentially merging some of those overlapping bodies, maybe folding NHS England back into the main government department, streamlining how the ICBs work, and rethinking commissioning, moving away from complex contracts towards focusing simply on patient outcomes.
And a shift towards prevention.
A big one. Rebalancing investment towards community teams, really integrating health and social care properly, boosting public health initiatives to try and, stop people getting so sick in the first place.
And finally, rebuilding trust.
This feels crucial. Maybe forging a cross-party agreement on long-term funding, taking it out of the short-term political cycle, and really involving staff and patients much more in designing how services run to restore that sense of shared purpose.
These aren't just small tweaks, are they? This is a comprehensive strategy.
Absolutely. It addresses the funding, the people, the structures, the technology. But the challenge, of course, is the sheer scale of it and the political will needed. It's not just about more money. It's about rethinking how the whole system works for the long term.
That's the massive hurdle. It's always useful, though, to look outwards. What can we learn from how other countries do things?
Well, the sources mentioned Germany and France. They spend a similar slice of their GDP on healthcare, around 11%.
Okay, similar spending levels.
And this is a big fin, but they have roughly twice as many hospital beds per person as the UK. And their more regional systems often give more power locally to tailor services.
Interesting. More capacity, more local control. What about the Nordics?
They tend to leverage their high tax models to invest heavily in prevention, strong primary care, digital health, good social welfare support.
And the logic there is?
That investing upstream in keeping people healthy and supported in the community reduces the pressure on expensive hospital services later on. It cuts demand for acute care.
And within the UK itself, there's this issue of the private sector.
Yes, the spillover effect.
Yeah.
As NHS waiting lists grow over 5 million in England now, private hospitals are attracting staff, often with better pay.
Which makes the NHS staffing problem worse.
Exactly. It drives up costs overall because the NHS might end up paying agency rates for staff who've moved or paying the private sector to do NHS work. And it can fragment patient care if people are moving between systems.
So looking at these other models, it really highlights the trade-offs, doesn't it?
It really does. More beds versus more prevention. Central control versus local autonomy. There's no single perfect system. It shows different countries make different fundamental choices about how they prioritize and deliver healthcare.
And each choice has consequences. It makes you wonder what choices the UK is or isn't willing to make going forward.
That's the multi-billion-pound question.
So let's try and pull this together. We see the NHS, born from this incredible ideal of social solidarity, is now undeniably at a critical point.
Yeah, facing this convergence of sustained underfunding, a really acute staffing crisis, and these deep-seated structural problems.
And its revival, based on what we've discussed from the sources, seems to depend on really significant interconnected changes: funding, workforce, tech, structure, the whole lot.
Yeah. It's not just one thing, is it? It needs that multifaceted approach.
And the sources leave us with a pretty stark warning, really. If the NHS is going to claw back its mojo, it needs blunt, honest fixes, more cash, simpler structures, and a real plan for people.
Otherwise, that promise, free at the point of use, could genuinely slip away from a bold promise into just a fading memory.
It's a sobering thought. So, what does this all mean for you, listening?
Maybe think about the sheer impact of having a system where healthcare is supposed to be free when you need it.
Yeah. How do we as a society balance that incredible ideal against the very real escalating costs and demands of modern medicine?
It's worth reflecting, perhaps, on how services like the NHS reflect our national values and what role we all play as citizens in shaping their future.
Thanks for watching the video.
We'd love to hear your thoughts. Feel free to share them in the comments below. If there's a specific topic you'd like us to cover next time, do let us know.
Don't forget to subscribe to the channel for more videos like this. And if you found this one helpful, make sure to share it with others too.
See you in the next video.